So now I'm going to move on to sort of how I got to where I am, and a little bit about myself and my kind of erratic journey. As you heard, I did quite a lot of climbing for a while. And then also talk about where we stand in world blindness. You know, we're all here because we're trying to do something about the people in our world who are needlessly dying blind. And what can we do, and where do we stand? And I'll kind of go through the overall fight. But I'm start out talking about Mount Everest. It's a three-sided pyramid on the border of Nepal and Tibet, or now China. And it's called Everest because Sir George Everest was a surveyor general of India. And just using trigonometry up from the Bay of Bengal, he discovered a peak he called Peak 15, and found it just with trigonometry to be within 20 feet of its actual height. Queen Victoria later renamed it Everest after Sir George Everest. And the people who live in the mountain shadow call the mountain Chomolungma, or Goddess Mother of the Earth. And the first people with the audacity to think maybe the mountain could or should be climbed again were the British. This is the British reconnaissance of 1921, and that's George Lee Mallory seated your view on the left. And he's the one who coined the phrase, because it's there, when asked why he was trying to climb Mount Everest. And he got high on the mountain in 1924 and disappeared. But before that, he circumnavigated the mountain in 1921. And it's sort of looking at topography in the mountains. It's just like looking at corneal topography. And you can see the eastern side of the mountain is by far the largest, but also the keratoconus side of Mount Everest. It's by far the steepest. And he looked at that and said, no, impossible by the means of 1921. He concluded other men less wise might attempt this way if they would, but emphatically it was not for us. And he went around to the north, which is the least steep side, but you're also up high a long ways. And he was just beyond that last little rock step on the ridge line with an Oxford undergraduate named Andrew Irvine, who I'll get back to in a couple of seconds. When they disappeared into the clouds, Colonel Noel Odell saw them moving towards the summit. And there's still some controversy over whether Mallory and Irvine made the summit of Everest or not. But if you climb, it really doesn't matter, because if you climb, getting to the top is optional. Getting down is mandatory. They didn't get down. So the first up and down trip on Everest was along that right-hand skyline ridge by Sir Edmund Hillary and Tenzing Norgay Sherpa in 1953. May 31st, and me, I was just a kid who liked to climb. I started rock climbing as a young teenager. I got very fanatic in college, and I never thought of going to big mountains. I never thought of the Himalayas. I used to read all the books, and these were like these superhero people, that you read about, but I never even thought anything. Still having a little trouble with my advance. My only goals in those days, I did a little bit of ice climbing. My only goals were coming out to Yosemite, doing big wall climbs. By the time I graduated from college, I climbed 7 routes on El Capitan. I was doing some moderate, eastern ice climbing, a little bit of mountaineering. But the thing that changed my life, I knew I wanted to go into medicine from a fairly early age. And I had a grandmother who was a Holocaust survivor who said, you're so privileged to be alive. You need to give something back. Tikkun Olam, you need to heal the world. You have the privilege. You should give back. So I kind of, from an early age, was indoctrinated with the idea of being a doctor. And when I was in college, I thought I wanted to be an orthopedic surgeon. I got really excited about sports physiology at the limit, and wanted to be an orthopedic surgeon. But then I was in college at Yale, and they put me up for the Marshall and Rhodes scholarship competitions. And I ended up getting the scholarship to go for 2 years to Oxford University to study philosophy. And it was the first time I got a chance to really sort of step back and think, hey, why do I want to be a doctor? What am I doing here? And I began also learning about the disparity between the haves and the have-nots of the world, and particularly in medical care and the aspects of both access and quality of care. So I was able to change my focus. I did a master's degree in philosophy, but I changed my focus from wanting to be something in orthopedic surgery to wanting to do something in global health. The other thing was it gave me a chance to climb. And Oxford had these indigenous trust funds that were remnants of the time that Oxford students explored the world. And one in particular was called the A.C. Irvine Grant for Oxford students to enjoy strenuous holiday in mountains abroad. And that was given in memory of Andrew Irvine, who died with malady on Everest in 1924. And my partner and I started climbing some routes in the Alps, but it turned out that the more exotic of a locale you chose, the more cash money they gave you. And so my partner and I started going on we went on 3 just really stupid, crazy trips where we were so far over our heads. We weren't the best 21-year-old climbers in the world at the time, but we were the only ones with Yosemite big wall experience getting funded to go to these remote places to try and climb big walls. And looking back, we were so close to the edge, and just a broken ankle in a couple of these would have been fatal. But we ended up getting really lucky with the weather. We had some great adventures. And then this is the north face of Karsten's Pyramid, which we did the first ascent of, which was a completely restricted area. And we had a missionary air fellowship pilot fly us in illegally. But on the way out, we got arrested, and I was incarcerated in Indonesia when I was supposed to be in orientation at medical school. And my local medical school, I showed up about 10 days late, and because I've been in prison, and my local medical school said, okay, well, we'll help you. And they were really fantastic in terms of helping me with my orientation. And then I talked about our trip, which was the climbing wasn't that cutting edge, but the adventure was pretty fun and pretty interesting. And I spoke at the American Alpine Club's annual meeting, which is sort of like the AAO. And a couple of my heroes came up to me and said, wow, that was a great talk. That was so cool. I'd love to climb with you sometime. And they came out and climbed with me on my East Coast climbing area. Where you're at your own home place, you seem a little better than maybe you are, and out of nowhere, I got asked, we have a trip fully funded by ABC Television Sports and National Geographic to climb the last unclimbed face on Everest. And I went, wow. yeah, I'd love to do. So I put in a leave of absence request from medical school. And then one of the things that really changed my life was I got a phone call. It's a real serendipity from a guy who said, is this Geoff Tabin? I said, yes. He said, you're an idiot. I said, excuse me? You're a complete moron. I'm sure you're the stupidest person ever accepted to Harvard Medical School. And I said, well, who is this? He goes, well, my name is Professor Mike Weidman. Does anybody remember Mike Weidman? He passed away maybe 10 years ago at age 97. He was the oldest operating surgeon at Mass Eye. Anyways, he said, I'm on the committee looking at leaves of absence from medical school, and there's no way, none, 0, less than that, you would ever get a leave of absence to go climbing. But anybody with half the intelligence to get into Harvard Medical School should know that if you apply to do research, Harvard will give you credit. And I'm an ophthalmologist, and I'm interested in the effects of high altitude on the retinal vasculature. And in specific, can we look at high altitude retinal hemorrhaging as a prognosticator of high altitude cerebral edema? So let's forget about your leave of absence, and let's talk about our research electives. So this was my research team. I'm the third one from the left in that picture. And my research consisted of taking a photo of everybody's retina before the expedition, during the expedition, and after the expedition. So 3 sets of photographs, 3 months credit at Harvard Medical School. And we actually published in Retina. We published in Ophthalmology. I presented at the AAO. And without this, there's absolutely no way I would have gotten into ophthalmology. So it's sort of real kind of serendipity. We did work out a route up this big rock face. It was a level of technical difficulty that hadn't been done on a peak the scale of Everest before. We had a big wall section, and we had 9 out of 9 climbers. We had no native support on the mountain. We didn't even have a native cook at base camp. We just 9 Americans. And everyone went above 25,000 feet for the sake of my research project. And this was 1983, so it was a very early time to be climbing Mount Everest. And I had a lot of really cool things come my way. I did more research in high altitude physiology. Actually, if you get I just got my new edition of the 2026 Harrison's Internal Medicine, and I still write the high altitude physiology and high altitude pathophysiology chapter for that. And after doing an internship, I climbed mostly for the next 3 years, and I worked a little bit at a couple refugee camps, and then I really, again, was seeing firsthand that disparity in healthcare access and quality, and I wanted to really get involved in global health. And I had gotten to know Sir Edmund Hillary through the climbing, and he's really one of my heroes, not just for his climbing, but for what he's given back, and his giving, building schools, building hospitals. And he asked me to work at one of his hospitals in a place called Phaplu in the low hills of Nepal. And it was really exciting being part of that community. I was just speaking with Lance about how important community is, and there's nothing like being the only doctor in a region like that. It was just such an amazing interpersonal community experience. It was also frustrating because I had people dying from simple infections that would be so easy to cure. I had children dying from diarrhea. And I had just finished filling out my applications to come back to the States to try and do a PhD in public health. And I thought public health was the way I could address some of these issues. When I saw the miracle of cataract surgery, and a Dutch team came in, Dr. Jan Kok from the Netherlands. Unfortunately, he also died about maybe 25 years ago from a glioblastoma, but really wonderful, amazing man from the Netherlands. And he came in and did cataract surgery with lens implants. And it was just crazy. I had about 40 people in my little catchment area who were totally blind, shriveled, looking way older than their actual age, waiting to die. And in Nepal, it was just accepted at that time. You get old, your hair turns white, your eye turns white, and then you die. And a Nepali name for a blind person is a mouth with no hands. And when you're in a subsistence agrarian economy, a mouth with no hands was a huge burden. And these people just blossomed back to life. And I went back to Kathmandu and I went, wow, who's doing this in Nepal? And there was nobody in late, this was 1989, no one in 88, 89 doing cataract surgery with lens implants. There were, at that time, only 4 ophthalmologists, and all of them were doing, von Graefe style, ICCE with loops, with +10 glasses. They weren't even using, Charlie Kelman's cryoprobe. They were just, and I went, wow. So I came back, I called my old professor, Dr. Weidman, and I said, you were right, because he had really encouraged me to go into ophthalmology out of medical school. And I came back from Nepal in May, called Dr. Weidman, and said, you were right. He said, well, there's a position that just opened up out of the match at Brown. And the chair there, Bill Sierras, was a retina specialist, and he had kind of seen our articles on high altitude. And I came back in May. I started my ophthalmology residency in July. So the problem, I'm still having a little problem with my clicker. I don't know if it's a battery issue, but the problem's huge. There on our planet right now, there are 43 million people who are blind, and that's not legally blind, unable, 2,200, this is unable to do the tasks of daily living. And it's about 350 million people have severe vision loss, or what we would call 2,400. And, it's cataract, uncorrected refractive error, and corneal opacity. And more than 90% of those people live in low-resource countries, and about 90% could either be treated right away or prevented. And you look at the global burden of disease, it's the 6th leading impediment to the world economy, $4,300 billion a year. And one of the other things that, as I'm trying to get more funding from a place like Gates says, well, we don't want to deal with non-fatal diseases. But blindness is a fatal disease. Once you go blind, there are several studies that have shown that once you go blind in a low-resource country, your life expectancy is 1/3 that of age and health-matched peers. And for children, it's much worse. And that doesn't even take into account, and the economic burden also doesn't take account the impact on this child who will never go to school and the lifetime loss of earnings because they have to lead their father around by a stick. You all know the leading causes of blindness, the cataract, refractive error is the #1 cause of low vision. And why we can't figure out a better way to screen for refractive error for every child and get really good quality, low-cost glasses to everybody who needs it, and then reading glasses to older people. We talked about cataracts and the challenge. And one of the other things, this is the same slide I showed before, but one of the problems is a lot of times the people who are really blind are getting cocooned behind those who can pay. I'm seeing it in India and places in Africa where as a surgeon gets, if you operate on just the blind people, we have about 15 million people who are unable to do the tasks of daily living, 18 million, 2,400 or worse. But if you start operating at 2,200, then it's 8 times that number. There's 60 million, 3 times that number. There's like 60 million people who would benefit from cataracts who have 2,200 legally blind in America. But if you start operating, on 20/60s, very generous. I operate on a lot of 20/25 cataracts at Stanford. And you start operating at the 20/60 level, it's 8 times that number. And if you're a surgeon and you're in India, you have an unlimited number of people with 20/60, 20/80 cataracts who are in this burgeoning middle class who want to pay to have their cataract surgery. So one of the things we need to figure out is how do we reach those destitute and poor, and how do we sustain that? And we did great with our compassionate capitalism model initially in Nepal. Dr. Rui was such a charismatic guy, and everybody was excited to be in part of the system. You're doing 3,000, 4,000 cataracts a year. You're becoming a great surgeon. And by doing high volume, we could bring the cost down, and we're doing 40% full pay. We make even more of a profit with phaco. 20% subsidized. We're really able to do the 40% free care and give everybody a good salary, from the nurses to the technicians, everybody. The problem is that the new generation who's coming out of residency, there's not that huge backlog of white cataracts in Nepal anymore. And they think, hold it, I can work like Dr. Tabin and Rui want me to, from 7 in the morning until 7 at night, and do 100 cases, 40 free, 40 full, 20 subsidized, and I make this amount of money. Or I can work from 9 to 4, and I can do 25 full-paying patients. And so we're starting to struggle a little bit with that cost recovery. Glaucoma is the next. This is one we really need to come up with and do better. How do we pick up glaucoma? As John Cropsey knows, a typical glaucoma patient is a 45-year-old presbyope who comes in because they're starting to have a little bit of trouble with reading, and then they've got a 0.9 cup and a pressure of 36, and no symptoms. And what are you going to do? And even though medications are available at sort of $5, if you're on $2 a day subsistence farmer, $5 a month for your glaucoma drops for something you don't feel, and then surgery. So we have to do better on glaucoma. Then overall corneal blindness, a lot of it is preventable, and trying to get in public health methods to, we're doing better on trachoma. That's one that economic improvements are going to really take care of. But we still see a lot of trachoma in sort of the Sahel and Northern Africa, Ethiopia. But trying to get early intervention and pick up infections early and really prevent corneal blindness is a really big thing. And working to try to set up eye banks. We've been in Africa a little better at training surgeons to do a corneal transplant than we are at at figuring out ways to overcome cultural barriers and set up eye banks, but even more, it's the follow-up. And the follow-up care has been a really huge issue. So corneal blindness is still huge. Onchocerciasis, we're doing a lot better. You know, the ivermectin program's been fantastic. We are doing better, but still in places that are hard to reach, in Darfur, South Sudan, Central African Republic, places in Congo, we're still seeing too much river blindness. Vitamin A deficiency blindness, it's still, tragically, in a lot of places, we're still seeing it. You know, we're doing better. There's less starvation in the world, but there's still places with food insecurity, still seeing some veto spots in South Sudan, and then the corneas will melt. And you know, the tragedy is this is the easiest intervention. It's 25 cents per child per year to overcome vitamin A deficiency blindness. HIV blindness is starting to come up, especially with our dropping PEPFAR. You know, when I first started working in Africa, I didn't see HIV blindness because everybody died. Now we're getting antiretrovirals, but not sufficient to get people Magic Johnson healthy, and starting to see more people with HIV getting opportunistic infections dying. Then the other big elephant thundering around the world is diabetes. And diabetic retinopathy is a huge issue. You know, in Ethiopia now, we've been trying to train retina specialists, but we have one retina specialist who will operate on the poor. And the access to anti-VEGF, the costs, and then also, you know, the difficulty with lasers. Diabetic retinopathy is one of our huge, huge challenges. So I finished my fellowship and I moved to Nepal in the early 90s. And I joined Sandak Rui. I'm sorry you can't really read that very well, but basically says that when I moved to Nepal, there were 7 ophthalmologists. There was only one doctor, Sandak Rui, who was doing surgery with IOLs. And the number 1 cause of blindness was cataract, but the number 2 cause of blindness was uncorrected aphakia. And people would lose their glasses and break their glasses. And the results of the aphakic surgery was so bad. There were a lot of people who were permanently blinded went from blind to blind and painful, that no one wanted to have it. So we had a lot of cultural barriers to overcome for quality. Then the finance, lack of doctors. We started training doctors to do better cataract surgery. And Sandak, you know, our inspirations were Hugh Taylor, who's the world's expert on both onchocerciasis and trachoma, and was my fellowship advisor in Australia. I did my corneal fellowship there. Fred Hollows, and then that's Sandak in the back. And they're the real geniuses behind anything I've been able to do. I'm kind of liking my role to being the fat boy who plays because I bring the ball. But that's been my main role. I went over to work with Rui. And I trained at fancy places, and I thought I was good. But it was amazing. I just was blown away. The system that he had developed where no one does anything anyone with lesser skills can do. And my first outreach with him was really, pun intended, eye-opening to me. It was amazing. He already developed a system of copious eye washing, betadine, antibiotics, preventing infection. We worked for 3 days on my first outreach. We did 224 cataracts, all on these mature and hyper-mature cataracts. And it sounds semi-impressive, 2 doctors, 224 cataracts in 3 days. But the breakdown was Dr. Rui did 201, while I did 23. And what was more, I had to call him over to help me at least 10 times, because I hadn't operated on a $5,000 microscope. I've been used to, the fancy $100,000 microscope. I wasn't used to the instruments. I wasn't used to these absolute things. And one of the big things that really changed the whole dynamic was the development of intraocular lenses at a low cost. Before 1990, the least expensive IOL on the world market was about $300, which made it just absolutely prohibitive for low-resource countries. And in 1994, we opened the Fred Hollows Intraocular Lens Factory in Kathmandu, manufacturing lenses for $4. In 1995, Oralab opened Oralab, and then Apaswami, and the whole advent of low-cost, really high-quality intraocular lenses. And it was just such a joy. And so I stayed, I worked with Dr. Ruiz, and again, our first thing was taking young doctors, but Dr. Ruiz had the brilliance that we couldn't just train doctors, we had to train the whole ecosystem. So we started a 6-month program after high school to train ophthalmic assistants, a 3-year program at Kathmandu University after high school to train ophthalmic technicians, a 1-year program from ophthalmic nurses, started working on developing the infrastructure, and we formed the Himalayan Cataract Project. We called it the Himalayan Cataract Project because we thought it was going to be a lifetime to get a handle on it, because there were, at that time, 250,000 people blind from cataracts. We had 3 doctors, myself, Ruiz, and then Rita Gurung doing IOL surgery. We were just starting to train younger doctors and started sending people for fellowships, but there was no one doing IOL surgery in Bhutan, no one in Tibet, no one in mountainous northern India or Pakistan. So the whole focus was really on training, and again, at the lower levels, but also all the way up through subspecialty training. And once we had a full component of subspecialists, we started a residency program in Nepal that is always matched with my American residency that I've been working at, and then subspecialty training and ongoing mentoring. One of the other things that was nice, Nepal was a small country. Dr. Ruiz was the sort of unavowed leader of the ophthalmic community. And then we were able to bring everyone together, all of the NGOs working. And Nepal is now the only, you've seen this video here, Nepal is now the only large poor country that's reversed its rate of blindness. And cataract surgery is really quite good throughout Nepal, but also retinal surgery, oculoplastic surgery, pediatric ophthalmology. I was trying to go back, but we started an eye bank, and one of the kind of fun, cool stories was that, when we first started the eye bank, no one wanted to donate an eye because they thought they would be blind in their reincarnation. So we moved the eye bank to Pashupatinath Temple, and we had Hindu priests and Buddhist monks asking for the donations. And with that, it's become the most successful eye bank in South Asia. And we have several sort of outreach cataract hospitals. We have the Center of Excellence with the full subspecialties, and then we also have these 3-year trained ophthalmic technicians and ophthalmic assistants dotted through the hills with primary eye care centers, which are seeing patients, trying to prevent corneal disease, giving glasses, and Nepal's the one poor country that went really to reverse its rate of blindness. And now I go to a remote area of Nepal, and a typical patient is a 20/30 pseudo-fake on the left who's walked 2 days to have their 20/80 cataract done on the right. And I think our last survey was in 2012. The prevalence was 0.35, but I think it's down to about 0.2 now. And now there are more than 400 ophthalmologists in Nepal. We train doctors in Tibet. The Chinese have now taken over that program, but very, very successful, fun program in Tibet. Started working in Bhutan in 1999, and they had no ophthalmologists. We started taking 1 ophthalmologist a year and training them in our Nepal program. Once we had 7 ophthalmologists, we started subspecialty fellowships. And in 2022, we opened a new state-of-the-art eye hospital and have a full residency in Bhutan. But again, as I mentioned, Africa is really the real continent with a lot of blindness and not a lot of resources. Cataracts are one of the things that also help with the sustainability in in Asia, is that most of the blindness and low vision was from refractive error and cataracts. And especially in Nepal, when we started working, if you carried your mom for 2 days on your back and brought her to the hospital, you had a 90% chance of a miracle. And so that word quickly spread. In Africa, there's more infectious blindness, there's more retinal blindness, there's more glaucomatous blindness, and cataracts are more like 40 to 45% of the blindness. So you have 6 people who carry their mom for 2 days to the hospital who don't get a miracle, and they're the ones who will talk. But the joy is still there. I relocated. Came back from Nepal. I was still spending about 3 months of the year there. My first faculty job in the University of Vermont. Then I got recruited by Randy Olson and Alan Crandall to start a division of global ophthalmology at the University of Utah. And Alan had already been working in Ghana, and it's been one of my, again, he passed away too soon, but Alan Crandall was one of the real greats, and he brought me to Ghana. And we started trying to transpose our system and the same sort of training ideas from Nepal to Ghana. And that was our first program in Africa. We've now done about 150,000 cataracts. We have 2 training programs. We just opened a center of excellence in Ghana. We have all those partner hospitals. One of the big things that we also initiated in Ghana is ROP screening. And retinopathy of prematurity is starting to come on as a big cause of blindness in children. And with almost scarcity of retinal surgeons, and it's been almost impossible. But we at Stanford developed a really cool little camera that a nurse can use and a non-dilated baby. And we're right now trying to screen we're working at all the NICUs in Ghana. We've just expanded to Ethiopia and to Tanzania for ROP screening. Ethiopia is our second program. We started working there in 2008. And South Sudan, we started working in 2010. We rebranded as the Pure Blindness Project. It's actually kind of interesting to see the difference in tribal reactions. This is in Tanzania. People get up and dance. And then you have you guys know about the Kalenjin people? A little side note. All of the sub 2:05 marathoners from Kenya are all Kalenjin, and they have this incredible stoicism. And I've done cataract surgery on 5-year-old Kalenjin children, and they absolutely still never move. And you do surgery on a person from the Chaga tribe, and this is a reaction you get. You do a surgery on someone from the Kalenjin tribe there. Can you see? Yes, very well. Are you happy? Yes. Anyway, so this is a woman in Tanzania who had actually never seen her baby. And she had polar cataracts, and she'd never seen her baby. She'd never seen her husband. She was darn happy to see the baby. I'm not sure about the husband. And I've been doing this now, since 1990. And I still, post-op day one, shoot, can we go back to, let's see. So anyways, we started in Eritrea in 2022. We have a residency program. We brought in Ethiopian and Nepali doctors to run the residency. We have our first 3 residents are going to graduate this year. And we rebranded a couple of years ago from the Himalayan Cataract Project to the Cure Blindness Project. And there's still a pretty good mountain of cataracts ahead of us. But just end with a very short video. We've all seen it, it's such joy. So elimination of blindness is something we can do. It really irks me. It'd be $14 billion. And we just appropriate $200 billion for our follow-up to the Bay of Pigs invasion in Iran. And for, $14 billion, we could eliminate all needless blindness from cataracts and refractive error on Earth. So, anyway, thank you, everyone. I think we have a panel, so I'll be happy to answer questions. I'm here all weekend. But thank you so much. Thanks, Ron, Dan. Thank you for having me.